We are live now.
Hi, everyone. Welcome to another webinar by the National Heart Center, part of the Saudi Health Council. In the next hour and 15 minutes, the focus of this webinar is going to be on the latest in terms of percutaneous ventricular assist device, and in particular, IVAC 2L device. Without further ado, I'm actually honored to chair the session along with my colleagues, Dr. Jose Andres Fernandez, who's a cardiac anesthesiologist from Jeddah, and also Dr. Farid Al-Huzali, who's a cardiac intensivist with a special interest in training in mechanical circulatory support, also based in the Western region. So we will start our first presentation by Ms. Maya Kurzai, and she will give us an update on the IVAC 2L technology. Maya can go ahead and get started.
Good evening. My name is Maya Kurzai, and I work as the Vice President of Sales in Pulsket. First, I would like to express our gratitude for this opportunity to present our technology. Thank you to the President of Saudi Arabian Cardiac Interventional Society, Dr. Wael Al-Kashkari, and we are very grateful to our partner in Saudi Arabia, company Arabian Trade House. Thank you for organizing this event. Today, I will present our product to you, IVAC 2L. I will talk about the setup and its function. I will explain the catheter positioning. I will emphasize indications, contraindications, and at the end, I will also summarize unique features of IVAC 2L. IVAC 2L is a percutaneous mechanical circulatory support device, and we are very proud that it is CE-marked under MDR. The technology actually consists out of several parts. The most important one, of course, is a nitinol reinforced flexible catheter, which is 17 French, a single port membrane pump, and we have a PTFE catheter inner tube for the reinforcement of the catheter during placement, and a catheter protector. The product comes also with accessories which are included in the kit. There is a Cook introducer sheet, 18 French, a 100 milliliter syringe, and a metal clamp for a wet-to-wet connection. But of course, there are several things that need to be provided by the hospital in order to have a successful procedure. We have to have an intra-aortic balloon pump console. Our technology is compatible with all intra-aortic balloon pumps on the market. Whether you have Aero or Datascope, all is okay. We also need a guide wire, a long guide wire, 260 centimeters, and it has to be super stiff. For flushing the catheter and for priming the membrane pump, we also need heparinized saline. It's not written here, but it is also important to think about the closure device at the end. So you might want to use a double ProGlide, Manta, or maybe you want to cooperate with a vascular surgeon. This would be the whole IVAC 2L setup. In majority of cases, the entry site is femoral artery. The catheter is placed in the left ventricle, and then the membrane pump would be connected to the intra-aortic balloon pump driver. In this case here, we can see a Datascope CS300, a very nice machine. And then, of course, we use the helium from the pump to move our membrane in the membrane pump. So the membrane actually pushes the blood in and out of the body. And when the blood is traveling through the catheter, it is moving the bidirectional valve, which is located 6 centimeters from the tip. As you can see, our technology works in a pulsatile manner. So during systole, we aspirate the blood out of the left ventricle. So we unload the left ventricle. The blood goes into the membrane pump, and then it is pushed back and during diastole ejected into the ascending aorta. So we increase the coronary perfusion. We have to be careful about positioning the catheter tip in the left ventricle. We don't want to go too deep. We don't want to go to the apex site, but we need to be in the upper part of the left ventricle. So not deeper than 2 centimeters from the aortic valve. This would be the appropriate position. There are certain scenarios where a patient could benefit if the catheter is in the supra-aortic position, above the aortic valve. This is possible with this product as well. We will talk about it also a bit more in the next minutes. IVAC 2L is intended for patients with impaired left ventricular function. Patients who can benefit from the device are the ones suffering from the acute myocardial infarction, cardiogenic shock, undergoing high-risk PCI, high-risk ablation, and mapping. This is very theoretical, but I want to share with you our experience during more than 6 years. And still now, our biggest experience is in complex PCI patients. And of course, it is a combination of different factors. It's about low ejection fraction, complex coronary artery disease, lots of comorbidities. Patients may be older and refused by surgeons. And then you also want to think about certain technology that you may use during the procedure, like shockwave, rotablation, IVUS. And with combination of all those factors, you may want to protect your patient during the procedure. If this is a very important document in European space. It's an expert consensus that was published in July 2021, and it clearly states that intra-aortic balloon pump during high-risk PCI should not be used because it's not strong enough. VA ECMO should also not be used because it's too aggressive. But technologies, so both technologies, IVAC 2L and Impella CP, are mentioned in this document as appropriate technology to be used during high-risk PCI if the femoral artery is of appropriate size. When we talk about cardiogenic shock, these devices offer partial support, and therefore they are appropriate for early stages of shock, not for deep shock. In deep shock, you may want to consider other more appropriate technologies. Another indication that I would like to mention is combination with ECMO. This is a nice publication that is also available on our website. It was done in Charité Hospital in Berlin. And the patient was first on ECMELA, ECMO plus Impella, but they had issues with hemolysis, so they switched from Impella to IVAC. And in conclusion, IVAC 2L was easy to handle during implantation and positioning. It provided pulsatile support for 5 days without requiring any replacements or corrections, and it resulted in less hemolysis than Impella CP. So we have in Europe and also out of Europe, we have a lot of centers who are using IVAC 2L regularly. And they have started using it also with other indications in other settings, such as, for example, mitral clip implantation. This is a case from Dr. Secco in Alessandria in Italy. He uses IVAC during mitral clip very often. And he explains that he first unloads the left ventricle to decrease the left ventricular size. So the reverse remodeling happens. And then the leaflets are closer together and it is much easier to clip. What is also nice is that the IVAC doesn't interfere with clipping because it is not too deep in the left ventricle. And if there would be an issue, they can always use IVAC in a supra-aortic position. The same goes for TAVI. This is also from Alessandria, also from Dr. Secco, because he uses this approach often to combine high-risk PCI and TAVI. So they use, actually they do a left axillary artery cut down by vascular surgeon. Then they do aortic valvuloplasty. Then they place a pulse catheter. They do the PCI. Then they remove the IVAC catheter, and then they place TAVI valve. All these procedures can be explained also into depth. If, for example, you would like to discuss with Dr. Secco this, we can arrange an online meeting, or we can also take you for a case observation to Alessandria. This is also another indication, IVAC2L support during VT ablation. It is very nice. It's also published on our website. And this was actually done in Malta, in Mater Dei Hospital by Dr. Balbi. There is another way to do IVAC2L with a sheetless approach. So the catheter is 17 French and the sheet size is 18 French. So Dr. Secco is in Alessandria very often uses a sheetless approach. We are very close to a publication, so you will be able to read the full story about this approach. However, it is important that you are used to the procedure, that you already know the technology before you go into something like this. But it does dramatically reduces the size. When we talk about contraindications, it's very similar to the contraindications for the intra-aortic balloon pump, but I would like to emphasize the femoral artery size. So you need to check the excess, you need to check the femoral artery, and it should be at least 6 millimeters. We've done also smaller, but you have to be cautious about it. And of course, there need to be appropriate closure devices in place. There are, of course, certain contraindications that you can bypass. For example, if you have a mechanical valve in place, ventricular septal defect, maybe sometimes you have a patient that doesn't tolerate a catheter in the left ventricle and they become very arrhythmic. In this case, you can use IVAC2L in a supra-aortic position. At the end, I would like to emphasize, I would like to point out a few features. For sure, pulsatile flow is more physiological, more effective in unloading the left ventricle, resulting in reduction of myocardial metabolic demands, and more effective in maintaining end organ perfusion. There is no significant hemolysis. It's actually less than 10 milligrams per deciliter of free hemoglobin after 72 hours. And that is very low in comparison with other continuous flow pumps. What is also nice is that you don't need any capital equipment to buy or to rent or to get used to. You can use IVAC2L in combination with your intra-aortic balloon pump, whatever you have available in the hospital. It's compatible with everything. And therefore, it's very user-friendly and the learning curve is very short. And like I explained, it can be also used in a supra-aortic position. At the end of the day, also from the economical point of view, IVAC2L is very affordable. At this point, I would like to thank you for your attention and I wish you a nice evening.
Thank you so much, Maya. This was really informative. We do have a question from the audience, but we'll reserve that question to after the second talk. That way we can also cover the clinical data. So in the next 15 minutes, we have Oren Malshin from Netherlands, who's going to be talking to us about the trials using the IVAC2L.
Good evening, everybody. Greeting from the Netherlands. First, I would like to thank the committee and the faculty for inviting us for this session. What I will do, I will share with you the last publication from a few weeks ago. It's a registry post-marketing surveillance for 304 patients, but we also did some comparison with the Impella CP. Maya mentioned that this technology, the IVAC2L, is a pulsatile system. So what is the difference for the patient between pulsatile flow and continuous flow? You all know the Impella CP, it's well known. So what we actually did, we introduced a registry study that it is very, very similar to the PROTECT 3 study with the Impella CP. We actually took the same baseline, and I will show you what are the differences between the two studies. So it's not a direct comparison between Impella and the IVAC, but it's definitely can be shown the one next to the other, and I think it's fascinating to see what is the actually, if there is a difference at all between pulsatile and continuous flow. And I think the big question is the IVAC is 2 liter and the Impella CP is 3.5 liter. And is it the same, or is it less powerful? So in this group of patients of high-risk PCI, what we found out that there is no significant difference with the clinical outcome. So what we did, we performed a study that runs in 30 countries. So it's a real-life experience in more than 70 centers. And that shows that this device was used in different environments, different doctors' skills. But we are very happy to see that the results were actually very, very similar. So if we look on the complexity of the patients, we're talking about syntax of average syntax of 33. Most of them were with low ejection fraction, of course, lower than 30%. The average flow of the pump was between 1.5 to 1.7 liter. 41% were left main treatment and 3 vessel disease with 57% of the patient. With the reports that we got back as a follow-up, we didn't see any repeat of revascularization. Major bleeding only 1.3%, even though it's a large bore access. We use the same sheath as TAVI. Hemodynamic instability is 7.7%. Total MACI in 30 days 4.3%. Hemolysis, clinical relevant, no hemolysis in this group of patients. Acute kidney injury were in 2.6%, and the CPR, escalation to CPR, less than 2% of the patient. What we really, and this is very significant to show, is that the hemodynamics was improved, a stable heart rate, increased mean arterial pressure, decreased wedge pressure, and the cardiac power output in that was increased by 30%. That means that the heart was relieved and improved and reduced its oxygen consumption. This is just an overview on the centers that we use. You can see all over the world, including the Middle East. And we use all type of console, as Maya mentioned before. It can be, and it's compatible with all console, but this is how the numbers of console that we used during the study. So the baseline, the average patient was, if we compare it to the Impella CP, very similar to the Impella group. The syntax score is a little bit higher. That means that our patients were a little bit more complicated than the study of the PROTECT 3. Ejection fraction 30 compared to 22. So our patients were a little bit more severe. But in general, you can see that all the baseline parameters were very, very similar to the PROTECT 3 registry. The hemodynamic effect that we recorded during the study itself So we actually took measurements before we started, 10 minutes after we started, and after we remove the IVAC. So you can see that all the main characteristics of the cardiac output and the mean arterial pressure and systolic and diastolic blood pressure were increasing immediately after we started with the IVAC, and some of them actually reduced, the cardiac output reduced, and this is logic after we stop. But you can see that the blood pressure remained high after the procedure, and this is due to the fact that the patient got a good revascularization because of the device itself. So if we conclude and we compare the demographic, as I said before, it's very similar to the PROTECT 3, and therefore we can conclude that the outcome, if they are similar, then we can say that we get approximately the same support as Impella CP. And this is the endpoints of our registry compared to the PROTECT 3. I need to be clear here, we cannot really compare everything because the PROTECT 3 was with the follow-up of 90 days and our follow-up on 30 days. So we cannot compare the long run or the medium time outcomes. But what we can compare is the in-hospital complications and in-hospital outcomes within the first week. And if you look on all-cause mortality, in hospital, 4.4% with the PROTECT 3 compared to 0.4% with the Pulse registry. If we look on major bleeding, it's about the same, and it's a question: how can 18 French sheath can have the same bleeding complication as 14 French Impella? And I will show you that the Impella is not really 14 French regarding the large bore management. Regarding acute kidney injury, it's 5.4% compared to our registry 2.16. Total MACI 5.4 compared to 3.3%. So in general, what we see is a little bit better, but is it significant, or is it something to say that IVAC is better than the Impella CP? I don't think so. I don't think that in this group of patients we have a big advantage over Impella. What we can say is that it's very, very similar with the outcomes. That means that the pulsatile 2 liter is getting the same results as the Impella CP 3.5 liter in this group of patients. And regarding the bleeding, what you see on the white one is the sheath of the Impella. Even though that the Impella is 14 French, the outer diameter of the sheath that you use the Impella is 18 French compared to 17 French, our catheter. That means that we actually need to close the same size of bore, the same size of a wound that we are creating. And this is why we have a very, very, very similar bleeding ratio to the Impella CP. Even though the Impella itself is 14 French, the large bore access management should be exactly the same. This is a kind of a meta-analysis from the last 10 years, compare all the mechanical circulatory support complication and endpoints. You see different studies here. The IVAC is the yellow one. So you can see on major vascular complication, we are in a very good position in between, in the middle. Regarding major bleeding, we are in a lower level. If we compare hemodynamics instability, we are also in the lower part of the others. So in general, again, if we compare mechanical circulatory support complication and endpoint, PulseCut is not very, very different from what we have in the market, but it's another option in your arsenal of treating failing heart. And this is another study, and I would like to talk for a second about it. This is the Pulse trial that comes from Rotterdam. And we actually checked pressure volume loop with the device in this group of patients. Again, syntax, you can see that it was 37, so very, very sick patients we treated there. And what we found out that immediately after we started the device, we saw an unloading effect of the left ventricle. And this is something that you would like to get with the mechanical circulatory support, especially in high-risk PCI. You would like to reduce the load of the ventricle and the oxygen consumption of the ventricle while you manipulate, for example, the left main or the circumflex or the LAD. When you unload the ventricle, the heart is relieved, the myocardial is relieved, the oxygen consumption go down, and then blocking or occluding with the balloon or with the stent, the left main, actually get to the balance. It reduces the supply, but if the demand is lower, then also the patient is not collapsing. And this is the whole idea with these devices, is to prevent the deterioration of the patient and the complication during the very fragile PCI patients. And this is a pressure volume loop comparison between the Impella CP, Impella 2.5. It's not relevant anymore because it's not in the market, but you can see a very big difference in the pattern of between the two devices. And this is the difference between continuous flow and pulsatile flow. The red one is before, and the blue one in both of them is after. What you see with the IVAC is a very clear unloading LV, but also you see a decrease of afterload pressure and movement of the loop all the way south. What we see with the Impella is a bit different. We see unloading, so the loop is shifting to the left, so there is a good unloading with the Impella. I'm not saying it's not good, but look on this point. This point is going up. That means that the afterload pressure with the Impella is actually increasing. And this is logic because you have a continuous flow in the ascending aorta with a high volume and that create high pressure. So it's very similar in a way to the ECMO phenomenon that you have overload, but it's not so strong, so it's not overloading the ventricle. But this is the main difference. And when you have this kind of afterload, that means that the cardiac power of the myocardial is actually increasing compared to the cardiac power that reduced with the IVAC. So this is the very very simple way to explain why 3.5 liter continuous flow get the same results as 2 liter pulsatile, because the synchronized pulsatile effect is actually giving a less workload to the ventricle, and therefore you can get the same result when you overload or when you manipulate the coronary. And this is to show the unloading effect. So we also look on the volume. So the heart, let's say, or not in this publication, the average was a 3 liter cardiac output without the IVAC. And you can see that when we activate the IVAC, the heart is reducing and the IVAC is actually overtaking the workload from the myocardial. Why it's important? Because we can see another study that published in Animal from Impella, because this is the only study on unloading from Impella. And this is a study that published with comparing ECMO unloading effect to the Impella CP. And what we see here, the blue one, I will not go into details, but the blue one is they create a shock model, early stage shock, and then they activate. So you see here they are activating the Impella, and what you see a very nice unloading of the left ventricle compared to overloading with the ECMO. But this is something that we already know. But this is a very, very nice unloading. But if we look very careful on the data, we can see that the change and the effective flow in this group of animal was only 0.2 to 0.8 liter per minute. So the effective flow of 3.5 liter in early shock model showed very, very small difference in cardiac output. If we look on the same group with the IVAC, the change was 1.2, 1.3 liter in the cardiac output. So we don't need to look what the pump is actually generating. We need to look what is the effective flow. What is the change in the cardiac output? The heart is compensating down because this is how the heart is working. But you can see that in this group of patients, or in this group, with the IVAC is patient, but with the Impella is animals, you can see that the change and the delta, even though that you are using 3.5 liter, it's only 1 liter change in the cardiac output. So it's very, very, very similar to the IVAC. Also here, you can see the same phenomenon as we saw in the pulse trial, that the afterload pressure is actually going up with the continuous flow pump. This is another study that coming from Rotterdam, and there were 198 patients compared between mechanical circulatory support arm to nothing. And in the group of mechanical circulatory support, there was IVAC, Impella, and PHP that is not existing anymore, but the IVAC was the biggest group in this one. And what they found out in general, that there was 50% reduction in procedure complication when you use mechanical circulatory support in high-risk PCI, and they didn't find any difference between the three devices. So they concluded very clear that if you use mechanical circulatory support, either Impella or IVAC, you will get probably decrease in procedure complication. So, and this is what these devices are actually meant to do. This one Maya already talked. So just to conclude this presentation, so we are now doing another registry with a longer follow-up of 1 year. The data is actually suggested equivalent compared with the Impella CP. The group of patients that been used in the pulse registry was a little bit more severe than the Protect 3, but altogether we can say that 3.5 continuous flow is very, very comparable with a 2 liter pulsatile synchronized flow. Thank you very much.
Thank you so much. That was really informative. I really like the fact that you've stressed on it's not just the number of liters, it's more that the pulsatility is giving you the advantage over other devices. I think a lot of people, and it's good that we have this webinar to kind of highlight that there's always this concern is why use a bigger front sheath with a less liters in terms of support. So you've highlighted nicely that the 2 liter pulsatility can give you the same effect as far as flow of the 3.5 with Impella. But I find it fascinating that your bleeding risks, regardless of the sheath size, that it's slightly less. And this is a registry data, but also there's a concern with Impella that real life data and meta-analysis that we're getting really higher numbers and reaching 10 to 12%. And one meta-analysis is actually 5% on average, but there are some studies of 12%. So are we anticipating that these numbers will be higher, or is this something that, reflective of true patients, population that you're seeing?
I would say the following. The fact that we have a very low bleeding ratio is due to the fact of that we used or the users of the IVAC are high-skilled large bore access doctors. This is very, very, very important. So they are TAVI, they are familiar with large bore access. So experience is a key factor of managing large bore access. Another thing and I agree that with the Impella, you see much higher than 3 or 4%. You see 5, 10, 12. But this is mainly due to the fact that they're using a pilloway sheath. And if you have a very calcified vessel and you take the sheath away, you have a 9 French in a very big vessel. So you will have bleeding, and it's very, very complicated to control the bleeding. So if you, from my experience and knowledge about the impella, if it's been managed by high-skilled, well familiar with large bore access doctors, you will not see 10% bleeding. You will see less than 5. And if you don't peel away the sheath, then it's much safer.
You do have a, remind me, you do have a peel, you don't have a peel away sheath, do you?
No.
It's just a regular sheath.
Yeah, we are using a regular sheath, and now we are doing many procedures without a sheath at all. That can be done with the IVAC, and you cannot do it with the impella because the impella is going from 14 French to 9 French wire, and we have one size all the way. It's advantage and disadvantage, of course, but the advantage is that you can use it without a sheath, and then you can even go lower than 6 millimeter and lower than the indication of the impella. But again, this is it's an advantage on one hand in this matter. But if you look on the lower limb complications and a perfusion of the lower limb, I would say that 17 French is big. So you need to think about that as well. And probably Professor Pawlowski will talk about his metrics, how to choose what. But in general, I think if you have a planned case that you believe that you will need a longer than 24 hours support, maybe to go with smaller pump, it's a better idea. So the IVAC is good, but it's not the perfect, unfortunately. So you have the option to decide according to the patient condition what is the best. So
and it is CE marked for 24 hours with the post PCI.
Yes. We officially it's 24 hours. The reason why we don't have more is just because the change of the MDR, and now we are filing the data for more. We have kind of off-label use up to 5 days and even 9 days, but in these scenarios, you need to perfuse the lower limb. It's like you do with ECMO. You can do an integrated sheath, 5 or 6 French sheath to the lower limb, and then you do a bypass and you support the lower limb. I would not leave 17 French in the femoral artery without bypass.
So you need a reperfusion cannula if it is more than 1 day, 3 days. Like this.
Even though sometimes we don't see a big reduction in the flow, I would definitely think this is important. This is needed. Yes.
And maybe question to you or Maya, any from the audiences, they're asking, is there any future reduction in terms of sheath size that the company is investing in?
Yeah, as I mentioned, we are now finishing the registration in the MDR with the 16 French sheathless. So it's comparable with 14 French sheath. And why I say it's comparable, because when you talk about sheath, you talk about inner diameter. And if you talk about catheter, you talk about outer diameter. So 14 French sheath is actually 16 French outer diameter. And we care only about the size of the bore that you need to close. So 16 French sheathless device that we are going to launch within the next 3 months is comparable like you use a 14 French sheath. So it's the same size. I would say one angioseal and one ProGlide should close it pretty much, or Manta, of course. All of them can close it pretty much easy.
Excellent. Before we go to the cases, maybe just one question to Dr. Fernandez and Dr. Hudali. They both manage patients with mechanical circulatory support all the time in the ICU. And for them, how common do you have to deal with hemolysis and having to remove devices because of that? And would you find this attractive option for such patients?
Well, I will take the floor now. So we have a kind of a big number of patients in a prolonged support with the Impella. They develop, all of them, they develop hemolysis. So, and most of the time, that's the main reason we need to remove the device, or bleeding. So I will say, just compare Impella with the IVAC 2 liters. In that sense, it looks very, very promising. The only thing I haven't just listened yet on the presentation is, have you used the IVAC 2 liters in cardiogenic shock? Everything you have mentioned, the two speakers, is just 3-4 hours procedures. So hemolysis in 3, 4, 5 hours procedure is something that you don't see very often. So that's why, just talk about hemolysis comparing the Impella with the IVAC is kind of risky. It's kind of a different thing. So do you have any experience with the IVAC 2 liters in cardiogenic shock, long-term support with the device? It looks very promising. I like the device in terms of pulsatile flow. It's very easy to handle. So in terms of cost for the hospital, the only thing you need to have is just buy the device and have the intra-aortic balloon pump console and connect it. But, I don't know if you have any experience with a long-term support with the IVAC to compare with the Impella, or even to compare with the intra-aortic balloon pump. Another thing I just really want to just highlight or ask. So when you inserted the IVAC 2 liters, so sheathless, do you have any special thing or you just suture the skin? Because I've been using the balloon for a while, sheathless. But the balloon has this special sheet coverage with a butterfly at the end that you insert in the skin close to the subcutaneous tissue, and that prevents the blood to coming out. Do you do the same thing with the IVAC, or something different with the IVAC?
If I may, I would like to answer the two questions. So regarding cardiogenic shock, out of the 304 patients, 28 patients were considered as shock patients with a very low ejection fraction. The support in average was a couple of hours, but we have more than 20 patients with support for more than 24 hours, 72 hours, even 5 days, 9 days. So there were no complications there because there was a bypass to the lower limb, so there was no complication with this one. But to be honest, I think if we talk about shock patients, deep shock patients, these devices are not designed for that. They are I would say, because it's a partial support, and the maximum you will get is 2 liters. And if you have a deep shock patient, you need probably more than 2 liters. So if you start with deep shock patient, I would not go with the IVAC. This is my observation on that. But if you're already in the procedure and you are there, then it's the best you can do. There is also and we have a very good experience regarding hemolysis, and you are right, within a couple of hours in high-risk PCI procedure, hemolysis is not an issue. Even if you have high hemolysis, it's not an issue. But for more, yes, especially when you are doing an ECMO and you need to unload the LV, then you have a lot of hemolysis with the ECMO, and you would like to have something that will not create additional hemolysis. So you can go through the subclavian, and this is a better choice when you have an ECMO, and you can unload the LV parallel with the ECMO. With this group of patients, we saw very, very good results without complications and very low rate of hemolysis. And if we go back to the shock, you probably know the danger study that just published from Impella. Everybody talked about it. It's questionable. There are some questions that I would like to ask over there as well, and especially regarding what is the difference between the complication rate and the mortality rate within the first week? Because these devices you use for 2-3 days, and if you did a good revascularization and good treatment, probably the patient will survive if you use it or not. So it depends on when you catch the patients, when you start the procedure. But if you already have a deep shock patient, I would not start with the IVAC. I think this is not the right thing to do. Regarding the bleeding, what you said with the IVP is correct. They have a kind of a cover there. We don't need it because it's one length all the way. So at the minute you put it in, it will not bleed, and we have good experience with that. So you don't need any cover. There are some tips and tricks, of course, but this is not for now.
No, great discussion. Unfortunately, we're running out of time. So Dr. Hudali, do you want one quick comment before we jump to the last presentation?
My quick comment is that if we are doing a patient in ECPR, and a patient with ECPR, as you said, Ms. Oren, we shouldn't think about the IVAC because it's during an ECMO insertion. But after we put an ECMO, you said it's pulsatile, so it's better to go with an impeller for LV venting. What do you think about that?
With the ECMO, you mean, to unload?
Yeah, no, I didn't, like I said, if I have a patient who I did an ECPR, okay? I did an ECPR, patient arrested, let's say arrested, and then doing an ECPR. And then after that, I chose to put an impeller instead of 2 IVAC because of there is no pulsatile. Yeah,
my question, did it work with a full cardiac arrest? The impeller? Did you succeed to activate it?
Yeah. And my whole training in Canada was all ECMO with all ECMO and impeller at the same time.
Yeah. Okay. With ECMO and impeller is one thing, but when you have a full cardiac arrest, that means that there is no preload to the LV.
I know.
And then when you have a pump inside the LV, you actually pump nothing because you have nothing to pump. And this is a big problem, not a big, but this is a disadvantage of continuous flow and the impeller, because the impeller can work only in the LV. The IVAC can work outside of the LV. And in these cases, I would put the tip just above the aortic valve and pump. And the reason why I recommend to do that, first of all, we have experience with that, so it's working very nice. And the reason is because in the aorta, you always have blood. So what happened, you do a kind of AA support. And that sounds, what is this? Aorta support, you actually start to create a flow in the aorta. And you actually, if the RV, is okay, then you will get a flow into the LV from the right side, because you are pushing blood from the aorta. So the vicious cycle that we all know and talk about is actually stopped, and then you start to put from the aorta, you start to push the blood to the right side, and then you have a preload, and then the heart is getting out. So you saw that. We had not so long ago a case. I was involved in the case, and there was a dissection on the right side, and there was no preload, and we had the suction problem. We had because there was no blood in the LV. Then we decided to take it out, and the patient came back within 60 seconds. So it was really really nice. And this is the difference between the impeller and the IVAC. So the IVAC can work in the ascending aorta, while the impeller, because of the technology in general, can work outside, but the alarms will start running with the impeller because they need these pressure differences between the tip and the engine. So this is the difference. So if you have this cardiac arrest, just pull it out and pump from the aorta, and you should get the maximum.
Excellent. Thank you so much for the tips. We'll move on to the last.
I cannot hear you.
You lost.
You are in mute.
You're in mute. Now.
No, we cannot hear you.
Muted, but for
Now,
some reason,
you're
I'm not
back.
sure why it's.
So you're
Can you
back.
hear me?
It's-
Okay.
Okay,
All
now
right.
it's
No,
That's
no.
good. Three times. All right.
No,
Again,
so-
thank you very much.
Thank you so much.
Thank you, thank you,
Great
thank you.
presentation. So we have the last presentation by Professor Pawlowski from Poland. He's going to share with us a few cases with the use of IVAC 2L device. You can go ahead.
Okay, thank you very much for the kind invitation. My name is Tomasz Pawlowski. I'm, wait a second, I'm trying to share my screen. Okay, I think it's visible. It's an honor to present some cases from our daily practice and generally from our past 2 years of, let's say, our adventure with IVAC 2L. Just for clarification, I work in Department of Cardiology in the Institute of Medicine in of the Ministry of Internal Affairs and Administration Hospital. So we are home for a Warsaw Group of Cardiovascular Intervention in Warsaw, WCCI. You can heard about it, and we have a lot of activity for Center of Excellence, for not only for IVAC, but also for some IVUS and FFR modalities, robot cut, also some decalcification tools that are play with. So before we start the cases, I would like to share with you some data with our very early experience with our Polish registry. So at the start we have 20 patients. It was collected 1 year ago. So the indication for this IVAC cases were not only left main disease but also multi-vessel disease, and of course last remaining vessel with relatively high syntax score of 34 let's say points, intermediate surgical risk. So the patient were scheduled for percutaneous intervention. Procedural success, and it was mentioned before that there is also option, of course, as a kind of bailout to have pop up the device that the IVAC 2L is located above aortic valve when it was impossible to implant it in the left ventricle, but or it pop up during the procedure. It sometimes happened, but in the majority of cases we had some success to implant. One failure to deliver the IVAC device was due to very extensive peripheral arterial disease. So immediate and 7 days follow-up was quite nice because we have only 5% of, let's say, major complication, including vascular and bleeding, myocardial infarction, stroke and death. So in this group it means only single patient. In 1 year follow-up we have 85% of survival. So it's very similar to this presented by Oren some minutes ago. So let me show you our three cases that IVAC is routinely used for the procedure. So the first one is 85 years old man. presented to us with the history of diabetes, hypertension, dyslipidemia, and the previous cardiac surgery more than 10 years before, and he was admitted due to non-ST elevation, myocardial infarction, low ejection fraction, and during heart team discussion, due to very high risk of so-called redo procedure. He was scheduled for PCI. So this is baseline angiography. You can observe tight distal left main and proximal circumflex stenosis. Highly calcified lesion, and due to low ejection fraction and need for atherectomy device use for this patient, we decide to support this case with IVAC2L device. This is his Lima graph, and no additional vein graft in aorta. Right coronary artery was occluded, so it's a very high-risk PCI patient. So we decide to puncture under fluoroscopy guidance this artery. It was big enough for IVAC sheet, and then we decide to use Safari guide wire to insert IVAC2L device. You can observe arterial sheet, so it's 30 centimeters sheet, so it is in smaller patients. It's almost reach diaphragma, so it's very safe for patient and safe for manipulation in aorta. So we place IVAC2L in the left ventricle, perform some rotablation with maximal 1.5 bar, and predilate this lesion with NC balloon, open balloon, and then finish with Megatron stent, and this is the final result that we achieve. And during this case, we haven't any pressure drop and hemodynamic compromise, and it was very nice supported by this device. Please appreciate the systolic movement of IVAC2L device. So it's normal, and generally it's not a matter of afraid to let's say injure the left ventricle, because the tip of IVAC2L is very soft and oblique, so generally it is safe for the patient. I'm telling it to you because most of us has the image of impeller device that is ended by pigtail device. So the IVAC was removed. It is very smooth removal, because there is also no risk of, let's say, mitral valve apparatus catch, and the artery large bore access was sealed by Manta device, and in our center, Manta device generally is let's say standard of care for this kind of procedures. It's very fast, effective, and safe for this patient in experienced hands. So case number 2 is also related to coronary artery disease, but the indication was multi-vessel disease. It was scheduled for 1 session PCI. So also it is patient with previous cardiac surgery, but perform much earlier than the patient presented before. And maximal Canadian class symptoms was 3. And generally, he was presented to our department for diagnostic angiography. And the angiography reveals patent lima graft and new lesions in right coronary artery in the intermediate branch. So after discussion in our heart team, we decide to perform multi-vessel coronary angioplasty supported by left ventricular support device. What is important, there was no area of akinesis or hypokinesis, good ejection fraction, but we realized that in this patient we have additional features that should be considered for high-risk PCI, so-called cheap angioplasty. So large word access also was achieved by fluoroscopic guidance. In this patient, we use contralateral injection just to puncture artery. We insert IVAC2L in the standard fashion using the standard extra stiff guide wire, and it is very easily to reach left ventricle. Please remember that also in intermediate aortic stenosis patient, it is possible to insert IVAC2L. So minimal in our lab, minimal orifice of aortic valve is 1 square centimeter, just for very safe placement of this device. Then we perform the angioplasty of right coronary artery. Please appreciate that it is very calcified, dominant right coronary artery, and generally for this artery, it took almost 2 hours to perform angioplasty using many decalcification tools, including rotablation and intravascular lithotripsy, balloon, many NC balloons, and finally we finish this angioplasty with 4 stents, and this is the final result. And the case was performed more than 1 year ago, and 2 weeks ago the patient was scheduled for follow-up angiography, and it was generally without any instant restenosis. So the second step, using the same support device, we aimed to perform distal left main and intermediate branch angioplasty after rotablation with 1.5 bar and predilatation. We use dedicated bifurcation stent bioslim C that was implanted towards intermediate branch, and this is the final result. you can observe that at this stage of procedure, we have, let's say, complication that the IVAC pop up to the ascending aorta, but the most important thing for this position is that if there is no aortic stenosis, IVAC2L it is possible to pump the efficient amount of blood to carotid arteries, carotid systems, and peripheral arteries, including renal arteries, so we can prevent renal contrast nephropathy, or for example low output complication related to the brain. And end of the procedure was also very smooth. Closure with MANTA, no additional problems with this with the patient. The case number 3 is a kind of let's say a case report, but it's very interesting. This was 85 years old woman with chronic angina, aortic stenosis, and low ejection fraction, and other additional risk factors for many of complications during treatment, including diabetes and hypertension. So she refused cardiac surgery, what was of course our first choice during heart team meeting. And we decided to perform PCI with IVAC2L, and in one session also implant a TAVI valve. Because very extensive peripheral arterial disease, we use surgical approach for the placement and access for this IVAC device, as well as for the TAVI procedure in the one session. And please appreciate that kinking of delivery sheet in subclavian artery, and it is very often observed also with Impella device. That kinking with right subclavian artery is frequent, but generally we were able to cross this with dilatator of IVAC sheet, and then we were able to insert very smoothly IVAC device through this subclavian to ascending aorta. Unfortunately, PCI of LAD and right coronary artery was unsuccessful, because you can see the image, and it was very difficult to wire the artery, and we stopped the procedure, just thinking that TAVI in this old lady is more important than PCI, but we attempted it at least. And then we start our TAVI procedure. Of course, you are forced to remove your IVAC device. And also there are some difficulties, because you see the kinking of the device, but please remember that IVAC is constructed with polyurethane, and then he's coiled by nitinol wires, and generally it is very soft and very plastic to vessel architecture. So then we start to place our Navitor valve under TEA guidance. Of course, it was not easy with this ejection fraction, and then we also experience cardiac arrest in this patient. So our cardiac surgeons that they assist us implant immediately ECMO pump for this lady, and it was possible to implant the valve. So please appreciate the flow in aorta and left ventricle after this cardiac arrest, but generally the lady was supported by ECMO device, and generally we were successful with this implantation. Very weak flow to the valve, but generally we were able to save her life, and according to our best knowledge, we use this IVAC 2L that we have on our table just to unload the ventricle during ECMO therapy, and please appreciate the flow, pulsative flow during this ECMO therapy. It's not the same as native one, but it was enough just to save her life and conclude the procedure. And just a few words from our side, because we are dealing with different flows, and as it was said before, it's not a matter of total volume of flow. It's a matter of comparison of pulsative flow and continuous flow, IVAC or contrapulsation versus Impella or other coming in the future devices. And generally, it's not an only matter of flow support, but it's a matter of, let's say, the flow continuous or pulsative in the same. So the question is, should we support or should we replace the left ventricle? So in some cases we can support. So the support is in the majority of cases during high-risk PCI, but the replacement of left ventricle in majority of cardiogenic shock patient is needed. So this is my personal view, and this is, let's say, comparison how to use IVAC 2L and Impella devices in daily practice. And generally IVAC is green and Impella device is red. So generally in quite good ejection fraction, that equals 35%. In the majority of cases, we can use for complex lesion last remaining vessel, low left main stenosis and atherectomy device need, we can use IVAC in some cases in intermediate ejection fraction, intermediate value. We can use also IVAC, for example, for complete revascularization of CTO cases, and it is very fine device, but very severe dysfunction of left ventricle with ejection fraction below 20. In the majority of cases, we can use Impella device. In some cases of complex lesions, atherectomy devices from all complete revascularization. Also, IVAC 2L is a very attractive option, and this is the, let's say, line of division between support and replacement. So in the majority of cases, supporting the left ventricle can be used, can be done with IVAC 2L device. Replacement, of course, with Impella CP or Impella 5.5 device. So thank you very much. That's all from my side.
Excellent. Thank you so much. Can you hear me now?
Yeah.
Good.
Yep.
Okay. All right. So you've actually, your last slide answered one of the questions that one of the attendees had is, how do you choose your device? So it looks like, in summary, just so that everyone is on the same page, that this device works well if you don't need much of support, and really well indicated for high-risk PCI as opposed to cardiogenic shock and late cases. There's really no RV support in this case. This is only pure LV support, correct?
Yeah, generally, regarding cardiogenic shock, we have no very clear data at this point. As was said by Oren, the problem of sheet size is quite important, and in the majority of cases, we should have some bypass from one artery to other, just to have additional blood flow in the distal part. And generally, in my practice, we haven't, let's say, direct indication for cardiogenic shock so far. Because the real limitation of IVAC in daily practice is the size of the sheet, because in the cardiogenic shock you are not able to use it sheetless in the first line. So you should puncture and insert 80 French sheets. So in cardiogenic shock with, let's say, some constructed vessel and unknown anatomy of peripheral vasculate, it's impossible to go directly. The other thing, for the other issue for cardiogenic shock is that we have very limited data according very low support with this device.
Great. And I think one of the attractiveness of this device is the cost. There are places where they're limited by budget and they can't really get other mechanical circulatory support. And the fact that you can hook it up to the balloon pump is also an attractive feature. What do you do the setting in terms of, one of the questions is, what settings do you do with the balloon pump? Do you use the same settings as a balloon pump and put 1-to-1, or how do you do it?
You mean is the same
Console.
is the same as a balloon pump? Of course, no. Let's say that intra-aortic balloon pumping is less effective, and generally for contrapulsation we have we as a community, and there is a lot of evidence that we have some responders and non-responders for intra-aortic balloon pumping. And generally, in the
I think the question is not the actual balloon pump, but you can use the same console, right, to attach your device.
Yeah. Generally, as Oren already show it that you can use anything you have. Intra-aortic balloon pumping available in your labs is connected to IVAC 2L. So generally, it's cheaper and less complicated for the cath labs because, for example, you have not to be forced to borrow land or buy special consoles.
And
So,
any
just a quick question, Rasha, just regarding the IVAC 2 liters and the balloon. So just comparing the two devices, I have a question for you. So the balloon has a very limitation if the heart rate is very high. So it's going to be the same thing for the IVAC 2 liters. So can you use, as when you are just dealing with the intra-aortic balloon pump console, you can use the internal, in the internal when you have a very high heart rate. Can you do the same thing with the IVAC? Yes, you have a patient with a rapid AFib, ventricular heart rate is 150. You put it internal. Can you do that with the IVAC?
Yes, maybe I can answer this question because it's very frequent situation because in very fast heart rate because optimal I think that it wasn't shown, but optimal performance of IVACs is with the heart rate 70-80 per minute. And generally, in some cases, when we have atrial fibrillation or tachycardia during the procedure, we can switch to internal mode because the internal mode it's a feature of intra-aortic balloon pumping console, not or IVAC or balloon. And we can just address this console as we would like, as we want. So generally, for this internal mode, also with ventricular tachycardia or ventricular arrhythmia, it's possible to have support with IVAC, and this is not the problem that we haven't any support during ventricular beats or ventricular tachycardia.
Can I,
all right,
Dr. Rasha, can I add just a few things? Yeah, thank you. So regarding the settings on the intra-aortic balloon pump during IVAC 2L procedure, there are a few steps that need to be done. We have also for every intra-aortic balloon pump, for every type, we have step-by-step directions how to prepare the device. Basically, in every intra-aortic balloon pump, we have to choose the operator mode. So it's not on the automatic mode, but we always go to the operator mode. We always have to increase the augmentation to maximum. We choose the ratio, so usually 1:1. At the end of the procedure, if you want to wean the patient off, You can go to 1:2, 1:3, so you can change the ratio. And also we have to turn off alarms because these devices are very sensitive to everything. So for example, because now the helium is not going to be inflating and deflating the balloon, but it's going to be moving, shifting the membrane in the pump. So the helium is going to travel a bit slower, and immediately there will be a slow gas alarm. So we turn off alarms. This is something that we, it's like a few buttons to push, nothing special. So it's very user-friendly, it's very helpful for the aero pump. So if you do have an aero pump, then you need to have an orange adapter. That's all that is needed. Usually we provide that. For the datascope, you don't need the adapter. And regarding the internal mode, like Professor Pawlowski mentioned, it is used, and we did some calculations and measurements, and we know that the most optimal support with the synchronized modes, so when the ECG is the trigger, the most optimal support you get when the heart rate is between 70 and 90 beats per minute. So if you have bradycardia, tachycardia, or arrhythmia, it is better to go to the internal mode. It's still pulsatile, but you're not synchronized anymore. But we still have a very nice support. And especially, for example, cases like VT ablation that I also mentioned, that is definitely, you have to be on the internal mode.
Excellent, very nice tips. Unfortunately, we have to conclude now, but any final remarks from Dr. Fernandez and Dr. Hudeli on the device? Just before I give the mic to you, I think we just have to recap that this is a device that's been approved for high-risk PCI with a 2-liter pulsatile flow, overall good data. There are some selected patients who can benefit from the device, and there really no head-to-head comparison between this and other devices. So it's good to have a variety and use the devices based on patient criteria. You can go ahead, Dr. Fernandez.
So I fully agree with you regarding the device and the indications. So maybe a downside is that 60 to 90 heartbeats, is kind of a limitation for using the device in a proper way. And the other thing I really just wanted to highlight. So when you are supporting a patient with the impeller, what is a continuous flow is a flow across the pump. But if the LV is working to your system, you are pumping pulsatile flow. The flow reaching your kidneys, your brain, lungs, or whatever is a pulsatile flow, all the time, unless your LV is completely down and you're just depending on the impeller. It's always good to differentiate that flow, continuous flow, or pulsatile flow is whatever is just moving across the catheter. The intraortic balloon pump is not a pump. You are pumping ileum into a special capsule. It's just moving according to the pressure. So I will say this device is very interesting. Maybe it's very cheap for hospital where you don't have a big budget to afford expensive devices like the impeller. And on the other hand, you have the console in your hospital to just connect the device and use it.
Yes. Maybe for the closure from our side, because I represent the company, I would just like to say that we have, at the moment, we have 9 centers of excellence. One of them is, of course, Professor Pawlowski's center. He is also our proctor, with a lot of experience, and we have a lot of other centers who are really experienced. If you ever have the desire to see cases, to go for a case observation, please let us know. Contact our partner, Arabian Trade House. They will direct you to you, and we will organize a case observation in those centers. So you can fly in, you can observe a case, and you can spend the day with a proctor who will answer your questions, who will have a discussion with you, you will do a patient. And we also organize a lot of teach courses throughout the year. So we have a lot of possibility for you to gain experience and to get more information about the product. And at the end of the day, the best experience is if you do a patient or two by yourself, and then you will for sure.
Yeah, for sure.
Have a better idea. Thank you very much.
For sure.
Dr. Hudali, any other final comments?
Honestly, no, but I like the idea that you just only buy the kit and you have it already on the console. That's one of the major advantage compared to other devices, honestly. But I hope the company consider a new generation that is less than 17 or 18 French. And this is my just only comment.
Excellent. Thank you so much. I'd like to thank the speakers, the moderators, and all the people who logged in. And we'll hope to see you soon on another webinar.
Okay.
Thank you.
Thank you very much.
Thank you.
Bye.
Bye.